Okay, so good afternoon, evening to everybody. And this is one of the active surveyor webinars we have been doing since 2 or 3 years. And we have always speaking about active surveillance and the things that are related to active surveillance. Now that active surveillance is becoming more and more used, and so I don't, let's say, more or less standardized as a protocol, as an activity. We have been working in the last webinar to look around what is in the neighborhoods of active surveillance, which is related. We looked to the active artificial intelligence application in the last webinar, where we have seen how is progressing the artificial intelligence to support the RMI interpretation in general. And today we are looking instead in something which is related to early diagnosis, we could say. They say we are seeing today that with PraisU, the study are becoming more clarified. We are going in a direction to suggest a protocol for implementation of pilot projects of early diagnosis. So that is a main important action. Obviously, in this environment, we are patient and we are curious on what is going on. So I thought useful to ask to Sergio Occhipinti of NIB Biotech to present what they are doing. They are a startup coming up from University of Turin, and they are particularly interested in working in the area of creating systems for let's say low cost, or if I'm not wrong to say that, simpler way to create early diagnosis. This is obviously just a curiosity for us. It's something that we are looking, and today we are not explaining this as a definite technology or application. We are interested to know, and obviously the scientific field, the doctors, the specialists will probably in the years coming, we will define how this could be implemented or connected to the early diagnosis. So today we have the possibility to ask questions in order to understand how much this is in the research, or how much this could be in the implementation in the future. So I introduce you Sergio Occhipinti, which is the CEO of NIB Biotech. And we spoke several times in the next years. We are doing something in Italy with him to understand and to present this technology. And obviously, I thought useful to present him in this European activity. So I leave the word to Sergio. Thank you for, in any case, thank you, and tell us what you are about this technology, and what you have been doing till now, and what you plan to do in the future.
Good afternoon, everyone, and thanks, Cosimo, for this introduction, and thanks to Europa Uomo for inviting us to make a small contribution to their dissemination work, and thanks to all the participants. So today I will tell you what we are doing in the diagnostic process of prostate cancers, both for early diagnosis, but even for monitoring active surveillance. And I hope that the results that we already obtain in our work will be interesting for you and can give some ideas for future collaboration. So I start to share my screen. Okay, can you see my screen now?
Yes, we can.
Okay, Okay, so this story starts a few years ago from the bench of the laboratories of the University of Turin, in particular from two different departments at University of Turin that have recently received the Seal of Excellence for the quality of the research results produced. So Department of Molecular Biotechnology and the Department of chemistry, and bring it together the skills gained in the field of research in oncology and analytical chemistry. Was born this academic spin-off called NIB Biotech, that is focused on the development of in vitro diagnostic tests for prostate cancer. So as you well know, prostate cancer is one of the most common oncologic disease in men worldwide. Last year, it was surpassed by lung cancer in terms of incidence, but we are talking about 1.4 million of new diagnoses every year. The diagnosis is made through biopsy to identify men to undergo this examination. It is necessary to carry out various tests, visit, and other procedures such as magnetic resonance to understand whether or not there is a suspicion of prostate cancer. And based on the outcome of biopsy and the degree of the disease, different therapeutic scenario can be selected by the clinician and the patient. Fortunately, today, most prostate cancer can be treated efficiently. So therefore, it's very important so early diagnosis is a key point for this. Unfortunately, men are still less inclined to perform prevention and screening exam as a woman for prostate cancer. And another problem is related to the staging. So it is very important to identify correctly the aggressiveness of the tumor, to correctly identify a specific therapeutic pathway. And after the diagnosis, is very important to have a specific tool to monitor the possibility of recurrence after a treatment, or even identify men that can benefit from specific pharmacological treatment such as hormonal therapy. So before arriving at biopsy, there are different procedures. So the PSA is for sure the pillar, and that is associated with the visit of the urologist, the risk factors such as age and family history. Magnetic resonance now is included in the guidance, so have a very important part of this process. So putting together results of PSA, histological examination, and evidence based on the visits. So it's possible to identify the type of tumor, so if it is aggressive or potentially indolent. So define a specific therapeutic option, such as active surveillance or surgery or radiotherapy and other treatment. So, and after treatment, through the evaluation of PSA or other blood parameters and other imaging techniques, it's possible to monitor whether there is a possibility of a recurrence of disease and or develop the resistance. So there are many factors, many exams that are available in all this process, but what is in a common of with all these parts is the PSA. So PSA remain today the only laboratory test used from the beginning to the end of the process, and so by now is the only laboratory test that have a meaning about the presence or the risk, the progression and the recurrence of prostate cancer. Okay, sorry. So in the last decades, there are several new tests has been developed and has been put into the market. So with the aim to identify a risk of prostate cancer. So try to solve the limits of PSA, such as the high rate of false positive results, but even the false negative results. So I think that in the past webinar, you already speak about this kind of new test, blood test, urine test, tissue test. So many examine tests that are designed, developed, and validated to be able to correctly identify the risk of prostate cancer, correctly identify the potential progression of this disease. So, but after several decades of research and development, the PSA maintain its role as the only laboratory test for prostate cancer. But in most cases, when the prostate became when develop a cancer, we know that the PSA increase in the blood. So the increase of PSA in the blood is a sign of presence of tumor, sign of progression of tumor, sign of potential metastasis. So several years ago, I think about this point. So in my head, as of researcher, I wonder why would a prostate tumor produce more PSA than a normal cells? So what does the tumor need from PSA? So the thing that I learned during my PhD is that if something is not useful for a tumor, there is no reason in producing more of this molecule. So our idea is that PSA is not so useful for the growth of prostate cancer. So let's let's start to understand what PSA is and what is used for. PSA is a molecule, is an enzyme that is produced physiologically inside the prostate and released into seminal fluids. And the function of PSA is to make the sperm more fluid to facilitate the motility of spermatozoa. PSA produced within the prostate can pass out in the blood. So a small amount of the PSA that is inside the prostate can move to the blood in a passive way. When the prostate is stressed, either for physiological reasons such as ejaculation, or due to micro traumas such as the use of bicycle, or due for several irritation such as inflammation or infection, the passage of PSA from the prostate tissue to the blood can increase. And even during the transformation from normal cells to tumor cell, we observe an increase of PSA in the blood. But in this case, a tissue in which a tumor develops undergo to deep changes in its architecture, structure, conformation, vascularization. So in the case of tumor, a larger amount of PSA pass out of the prostate tissue to the blood due to this changing in the characteristic of the organs. So to demonstrate that there was no increase in PSA production in prostate cancer, so we analyzed the tissue taken from surgical specimen deriving from prostate that has been removed after prostatectomy. As you can see here, there are two slices of prostate that has been stained for the expression of PSA. So as you can see here in brown means a high expression of PSA. So this one is high expressing PSA, and the other one is no expressing PSA. And as you can see here, so the first one is coming from a tumor that have a low Gleason score of 6, while the second one comes from more advanced cancer, so a Gleason 7, 4 plus 3. So in this case, there is a suggestion that during progression, so advanced cancer lose the production of PSA. Starting from this, we ask if it could be possible to analyze what happened inside a prostate without picking a piece of tissue. So our idea is to use urine as a source of molecules that come from the prostate. So our idea is that after a prostatic massage is possible to extract the content of the prostate and evaluate easily in the urine, and that this urine can reflect what happened inside the prostate. So from this preliminary analysis, we observed that there was a direct correlation between the intensity of PSA in the tissue, so expressed by staining with performed by a pathologist, and the amount of PSA that we observe in urine. So the more PSA is in the tissue, the more we can find in the urine. So starting from these preliminary results, we can suggest that it's possible to use urine as a source of on liquid biopsy. And what is very interesting is that as we analyze the level of PSA in the urine of these two samples, as you can see that the histological piece that express high amount of PSA display high amount of PSA in the urine, and by contrast, the urine coming from a patient that have very low amount of PSA in their prostate tissue have a very low amount of PSA in urine. So starting from this evidence, so we have the idea to analyze the amount of PSA in urine coming from men with prostate cancer or risk of prostate cancer, and evaluate if there is a direct correlation between the amount of these molecules and the presence of a tumor and the stage. So we use urine samples collect in our retrospective studies. The urine has been collected after a standardized prostate massage, and the sample come from a studies in which men receive an indication of prostate biopsy due to the normal standard parameters such as PSA, digital respiration, or magnetic resonance. And the results of biopsy from this cohort of patients has been that the 40% of men receive a diagnosis of clinically significant prostate cancer, 5% receive a diagnosis of low-risk prostate cancer, and 55% have no sign of malignant disease. So we analyze the PSA in the urine coming from this patient, and as you can see here, the urinary PSA was lower in patient with intermediate risk and high risk cancer compared to the healthy subjects indicated here as an asterisk. And moreover, the amount of this the PSA that we found in this advanced patient was very low, statistically lower compared to the patient with tumor with low risk. So we observe this the low amount in advanced cancer, but more importantly, we observe a trend, so a linear trend. So with the increase of Gleason score or aggressiveness of tumor, we observe a linear decrease of this molecule in urine. So after that, to evaluate the diagnostic capability of urinary PSA in correctly identify a patient with prostate cancer and a healthy subject, we designed 3 different predictive models. One with the standard parameters such as blood PSA, age, and the results of digital rectal exploration that we call the standard of care. Another model considering just the urinary PSA, and a third model that combine all these parameters. And from the analysis of the ROC curve, we can see that urinary PSA is already better performing than the standard of care. And by combining all these factors, it is possible to have an even better diagnostic capacity. So to validate the results, we measure urinary PSA in a second cohort of men candidates for prostate biopsy, and we apply the predictive model that we design in the first cohort. So as you can see, the different models perform in a similar way to what we already seen in cohort 1, confirming that urinary PSA can display a better diagnostic capacity compared to the standard parameter. So starting from the same principle, so we thought that other pathways, other function of the prostate could be compromised in a similar way during the transformation in cancer. So PSA is a normal product of the prostate. The accumulation and secretion of zinc is another specific characteristic of the prostate, and generation of other metabolic products such as spermine are very specific on the normal function of the prostate. And our idea is that all or part of this pathway can be damaged during the progression in tumor, and can be compromised. So the idea is that in advanced cancer, we can find low amount of all these elements inside the prostate, and even inside the urine coming from patient with advanced cancer. So the prostate is divided into 3 main zones, so mainly peripheral zone, central zone, and transition zone. And the peripheral zone is the area where most of the content of the prostatic fluids are obtaining, and is the area that where the majority of tumor affecting this organ develop. And the peripheral zone is also the one that is evaluated during rectal examination or prostate massage. So all these aspects confirm that we can collect prostatic fluid or urine with the prostatic fluid after digital rectal exploration to evaluate the amount of this molecule and evaluate the possibility to use them as a biomarker for prostate cancer. So first we concentrate after a PSA to the zinc. The prostate is one of the organs in our body that mainly accumulated zinc, so actively absorb zinc inside to perform several activities. And there are several publications, several evidence about the fact that in pathological situations such as tumor, the capacity of prostate cells to absorb zinc from the bloodstream is compromised. There are several evidence say that the channel of the pumps that actively put inside the prostate the zinc are loose during the transformation. So starting from this idea that confirm our hypothesis, so we start a new studies that we published in 2022, where we evaluate the amount of zinc in urine coming from men with that receive an indication of prostate biopsy, and we compare the amount of zinc that we evaluate in different subtype of men, so men that have no sign of cancer at different class of risk of patient. And in a similar way that in which we observe for PSA, even for zinc, we observe a very lower amount of zinc in urine of intermediate and high risk prostate cancer compared to healthy individuals, but even compared to men with the low risk cancer. So as the PSA, even the decrease of zinc can be an indication for the presence and even for a predictor of the progression of prostate cancer. So all these analysis has been performed on retrospective studies. So with the updating of the European guidelines and the introduction of magnetic resonance as a test to be performed in most cases before undergo to a biopsy, we decided to design a new prospective studies to test this combination of biomarkers, so the use of contemporary urinary PSA and urinary zinc in men candidate for prostate biopsy to evaluate the capacity to correctly identify the outcome of the biopsy. So, but we first asked ourselves what characteristic a test or an examination should have to have a strong impact on clinical practice, but mainly on the patient life. So obviously the test must be sensitive and specific enough. So therefore, correct identifying both men that have cancer and those that don't have cancer. Must be this test must be easily accessible to all men, so or at least to the majority of people, not just for those who live near large referral hospital, but even it must be accessible at low cost. What emerged from an European survey is that most people perceive some barriers to access healthcare service, even the basic ones. Among the people interviewed, it emerged that the distance from specific health facility represent a one of the main problems. But before this, we find that the the cost of this procedure is considered too high as a basic healthcare service. But first, the, uh, the majority of people interview consider the waiting list as the main problem to access healthcare service. So putting these different needs together, so we decided to develop a test that could possess all these characteristics. So therefore, we start to develop the prototype of a rapid test for contemporary evaluation of PSA and zinc in urine, a test that evaluates these with the presence and the progression of prostate cancer, and that test that can be used in a hospital, in a clinics, in a doctor office. So therefore, decentralize the procedure of prevention and screening, and a test that can return the results in a few minutes, so reduce the long waiting list, and a test that can be offered at an affordable cost. So starting from the results that we obtained previously, well, we identify the optimal threshold for this for these two biomarker, and we design this device that is a rapid test. Probably you already are quite familiar with this because are very similar to a pregnancy test or a COVID test that evaluate the presence of these two molecules. So in urine, PSA and zinc, and when the amount of these molecules is in the urine sample is over a specific threshold that we already identified, the test gave a positive result. So potentially an indication to perform or not other exams. So we design a new studies that are still ongoing, but we already recruited more than 200 men with indication of prostate biopsies. Of this, 61% receive a diagnosis of prostate cancer. So if we look at the PSA and urinary zinc, we can notice a clear difference between healthy individuals and men with advanced cancer. So as you can see here, so the amount of these two molecules for men that have high aggressive cancer, so ISUP 4 or 5, have the amount of these molecules are in this range of value. So we identify the range of value that identify all the men with advanced cancer. And as you can see here, in the same range of level, only the 38 of healthy subjects have this value. And if we compare this subgroup in the different class of patients, we can observe that there is an increase of the person that is that belong to this level of molecules. So we analyze the urine samples coming from this patient, and we combine the result that we obtain with our urine test with standard of care and MRI, and the combination of our test with other models. So as we observed before, so the diagnostic performance of our test is significantly better compared to the standard of care, and this is similar to the results obtained by the magnetic resonance. And as you can see here, so if we combine the results of our test with the parameter commonly used for the selection of candidate of prostate biopsy, we can see that we can improve what is already done in the clinical practice. So improve the capacity to discriminate person that will have a negative results on biopsy from men that have a diagnosis of prostate cancer. So what the results of this preliminary test is that we observe a high sensitivity of our test, so high capacity to correctly identify as positive men with prostate cancer, with a specificity that is very, very higher compared to the PSA. So the results of this preliminary evaluation is that our test, the use of our test, can potentially avoid the unnecessary the 50% of biopsy performed to healthy individuals, so biopsy that are not necessary. And as I told you, so we set up the test to correctly identify all the aggressive cancer. So the false negative rate for ESUP 4 and 5 is 0%. So the risk, we absolutely reduce the risk to miss patient that needs to undergo surgery or radiotherapy, other approach for advanced cancer. So okay, so yeah, one of the point that we have to clarify is if our test is able to discriminate clinical to non-clinical significant tumor. This is due to the fact that the guidelines has been changed. So the group of patients that receive a diagnosis of low-risk cancer is reduced compared to the past. So even in our court, there is a small group of this patient. So our idea is to use our test, so the same test that I showed you before, in a program of active surveillance. So the idea is to test if our device or our urinary test is able to identify in a group of men that have a potential low-risk cancer, that have a low grade of tumor, can really benefit from active surveillance instead of other treatment. Okay, so active surveillance, I know that is a very interesting point for you as an association, but mainly for all the patients, because the problem of active surveillance is that there is no a fixed program. So in around Europe, but even inside the same country, there are different active surveillance program that share several inclusion and exclusion criteria, but there is no consensus to all this procedure. So even the guidelines are few compared to the the screening. So at least in Italy, active surveillance is a procedure that is used uh, very lower compared to what he can choose. So this means that lot of men that receive a diagnosis of low risk cancer in most of cases decided to undergo surgery or radiotherapy. And I think that the main problem is that patients are not so informed regarding the pro and cons of other treatment. So the side effect of surgery or radiotherapy, such as impotence or incontinence, are probably not so understood by the the patient. So. I think that you already know the PREAS study, so is one of the largest program for active surveillance that has been performed in Europe. There are the inclusion criteria include the men that have a low risk cancer, so with a Gleason score of 6 or at maximum of 4, if even if the in case there are no sign of aggressiveness. And this is the protocol of this program. So there is several visits, several test exams during several years. So the patient will be monitored over the time to understand if there is potential progression of the tumor, could be indolent disease. So to evaluate the possibility to use our test not only in the screening process, but even for identify correctly the men that can benefit from active surveillance. In parallel of the study that I showed you before, so we start to recruit men that enter into two different active surveillance programs that are active here in our region, in Piedmont, in the north of Italy. One is the so-called START studies, and we recruited even patient that has been introduced, selected surveillance with a specific protocol in use in the urology department in which, by which we are collaborating in the hospital here in Turin. The protocol is quite similar to with the prior study. So we consider a time lapse of 1 year. In this 1 year, the patient perform 4 PSA evaluation and 3 visits during the year, and 1 repetition of MRI at half of this process, and at the end of the process, so after 12 months, they undergo to another prostate biopsy to verify if there is a progression or there is a stable disease. In this study, we collect urine sample at the day 0, so before to enter in this program of 1 year, and after 1 year when they perform the biopsy. So 89 men risk has been evaluated by now. And of these 89 patients, after 1 year, 20 patients show a progression of disease and go out of the active surveillance program. And the other 69 have shown stable disease since entering the active surveillance program. What is interesting is that, as I told you, we evaluate urine for the amount of zinc and PSA before starting the program and at the end of the program, and we observe no variation of these molecules during this period. But what was emerged during this preliminary study is that in the 70% of men that display a progression of tumor, our test results as positive. So 70% of men who do go out from active surveillance program have positive results of our urine test based on PSA and zinc. And by contrast, only 22% of patients whose cancer remain stable had a positive urine test. So this is the preliminary results. The study is still ongoing. We are continuing to monitor this patient and collecting sample from other patients with low-risk cancer that come into this protocol. So just to summarize the result that we obtained during these years in these different studies. So the use of the prototype of our urinary test show that the evaluation of urinary PSA and zinc can be an interesting approach to evaluate the risk of developing clinically significant prostate cancer. So to identify in naive man the potential presence of a tumor, but even the potential progression of the disease. Currently, the test can be used in addition to the normal clinical practice. So therefore, in association with the standard PSA evaluation, the DRA exploration, and magnetic resonance. So we are evaluating the possibility to design new protocol in which our test can be used. So we are interested in evaluate more patient, more situation, more center to improve the evidence of these preliminary results in define a more strong test for prostate cancer. So by now we are working on this test. So this rapid test that is now under evaluation. So during this year we will move on an industrial phase. So we will produce the final version of this device by the end of this year, and the idea is to start clinical validation to test the clinical performance of the test in a clinical setting in the next years. And this program is being funded by the European Communion. So we will have the support to perform the industrialization and validation of this device. But yeah, we will even work on other tests that can be used in other point of the diagnostic and therapeutic part of prostate cancer. The one is the one that I introduce you now. This is a similar test that can be used during active surveillance program. So to identify at the beginning, but even during the program, if the man can benefit for a long time from an active surveillance program, so can delay or eliminate the needs of surgery. And in the near future, we will start to work even to another test that can be used before the test for the urologist to identify a general disease pathologic situation. So not just a tumor, but even other pathology. So a test that can, I think, bring more men to perform first visit and prevention. So that are all a summary of the preliminary data that we already obtained. So I hope that this information can be interesting for you. So I'm here to answer to your question, and thank you for your attention.
Thank you very much, Sergio. Even as a patient, so not so expert, but it was very clear, and you explained very well what is under your technique. So now I think there is questions, because certainly someone of us has more experience of this type of things.
I have a question.
Yes.
Yeah.
I listen. I'm wondering what if it's possible to use, or in the future will be possible to use your method after surgery to eliminate the risk of to have it again or something.
Yeah, sorry, I missed several words. So can you?
I mean, after prostate surgery, is it possible to make the same method to test if it's cancer coming back or not?
Yeah, we are working on a completely different test. So even by using the same molecules, but in an opposite way. So as I showed at the beginning, so we evaluate the decrease of these molecules that could be a characteristic of tumors. We know that when the prostate has been removed, so the patient have a very, very low amount of these molecules in urine. We perform several tests in the past on men that underwent to surgery, so without prostate, to verify if it's possible to evaluate the risk of recurrence. And in few cases, because we collect very few samples, when we observe an increase of these molecules starting from zero, there is a correlation between the clinical recurrence evaluated by the PSA. So this is a completely different story. So this is an R&D project. We plan to restart old project, and one of this is one for evaluate the risk of recurrence. Another point is that we evaluate if the amount of these molecules can be correlated to the responsiveness to hormonal therapy. What we observe that the patient that have a very, very low amount of these molecules are mainly refractory to hormonal therapy. So probably they are very, very aggressive cancer, completely transformed cancer. So now we are concentrated in develop tests for the first part of the diagnostic and therapeutic pathway of prostate cancer. But yeah, in the future, our aim is to start to develop specific test for all these part of the process.
Thank you. Thank you. Anyway, I want to say it's a really revolutionary, thing with, you're working with. Thank you very much.
Thank you.
I think Eric has a question.
It is, sorry, it is more a comment. And I will disclose I am an in vitro diagnostics expert. That was my past life. I'm a scientist. So I look at this from a different perspective, and I congratulate you with all the work you've done. Very nice results, but it's important that my colleague patients, that they know that the time needed to bring this to the market can be very long. We are talking not months, but it can be years, because you need to have a medical device regulation. This is a product that is classified in Europe as highest risk, because it has to do with cancer, and you're doing a test for cancer. So a diagnostic for cancer is highest risk. So the requirements for an approval are the highest. That's one. Second, something that I don't like to see, and here is that you are 100% sure that is 0% false negatives. I don't like that, because that is never, ever true. And I like to see the real results. And I know that also on your slide number 14, for instance, you show the different classes with the urinary PSA, and the overlap between the different groups is gigantic. And that's where I'm worried, because your results are true, but they are statistical, and statistics go over the population. And in a population, you can be relevant, but you have to think on a specific patient. So for this patient, he may fall out of this range and be classified as healthy, where he should have been classified as diseased. And these are just a few, because I could go much further, but still the work is very, very good, elegant, needs to be continued, but the time is much too early to bring that to us, because this test is not available. We cannot ask for it in Belgium. You cannot ask for it in Sweden. It is not available. And the last point I want to say is you have designed and you want to market it as a qualitative test. It's a yes or a no. As someone who comes from the laboratory medicine world, I don't like that. That's personal. I want figures, and I want to be in evaluation. PSA is a value. It is less than 10 nanogram per ml. And to that you add positive. And who is going to read the zinc results? Interpreting colors, as you know by now, is very delicate. You should do a test with lab people and people around to measure, to read the same color result and to score it. And then we'll see that there's already big variation among the readings that they all make. So it's a pity that you sound so negative. It is really nice work, but you still have to do an awful lot, continued research before you can go anywhere. And I would prefer you to make a quantitative test, which has a result that can be used, and not a qualitative test where the variations from the person who is doing the test are too much influential on the positive or the negative. Thank you.
Are there other questions?
Yeah, just to answer to the last question. So the test is a semi-quantitative test. So we identify a scale of the results. We start by identifying yes or no test. This coming from a survey that we give to several urologists. So if it would be better to have another parameters that needs to be interpreted, such as the value of PSA, say the other parameters. So it's better to have a specific indication of there is a risk or there is no a risk. But yeah, the test can be interpreted as a range of positivity. So as I told you, we observe a linear decrease of these molecules, and we observe that different intensity of our test can provide not just there is a tumor, but even there is a more risk of aggressive tumor or more probability of a low risk tumor. So the idea is in the future to associate this test with a machine that can read the test and can provide not just a yes or no, but even a value of positivity.
Thank you, Sergio. I don't know if there are other questions.
May I give just one quick contribution? Actually, I'm Maurizio Ballerini.
Yes, please.
Actually, I'm a medical doctor, but I'm working since 15 years in the biomarker field on prostate cancer. I'm the one actually who developed in Italy and in Europe PCA3 first. And together with Select MDX later, they are both now in the guidelines. And I'm pretty curious actually about this new test. It is true that actually probably that won't be available in the short time frame. So anything needs to be regulated. On the other hand, I have to say that both Select and PCA3, they were giving scores. And every time most of the urologists I've been working with, they ask for a yes or no solution, especially on a screening setting. So for sure, there's other procedures, other techniques for deepening this matter. So in the diagnostic pathway, so to say the MRI, so to ultrasound or whatever. But on the very initial phase, they would just ask, I don't want a test which just giving a probability. I want to know if it is a yes or no regarding a calcium present. This is just my experience that I would like to share.
If I may say something, so this is the end result. The end result is yes or no, higher risk or not. But what we want to know as patients is what is my risk category if I am positive? Am I a low risk according to the AMICO, intermediate risk or high risk? Because according to the guidelines, I'm in the guidelines panel of EAU, the starting point where we will decide what treatment you should get. If you're a low risk, there is no doubt you will go into active surveillance. That is a result of patient intervention in the guidelines committee. If it is an intermediary risk and it is a low intermediary, we can discuss. Maybe you can also go into active surveillance because the side effects of active surveillance are the lowest. There is no impotence, no incontinence. There is psychological issues, of course, because you have to help these patients. It is not a free ride, but we need this classification of the patients. If we can improve this with adding a very cheap test without adding cost or without adding effort, then we are in favor. But we should not underestimate what a prostate massage does to a man. Not every man will be very happy to have this. It looks non-invasive, but it is invasive. And two, they should also know to take the blood draw for the PSA before they do the massage. Otherwise, the result of the PSA test in the blood will be falsified gigantically.
One last question to Sergio. Based on what you have told us, when do you expect that this is going to be approved by EMA?
Yeah. But we need several times to perform validation and obtain certification. So yeah, we plan our strategy to obtain this CE mark for this class C test. So our plan is to complete industrialization of this device by this year. In 2025, we will perform a validation and start the process of certification. So our goal is to obtain the approval by we obtain CE mark for the commercialization in 2026.
Yeah, that may be a good estimate, but it is important that it's not the European Medicines Agency that gives the certification. It is certification through a completely different path. It is a certified body, a notified body that will do that. But that's not to the point. It is still a process that has to go on. And if you say 2026 and you can realize that, that is a fantastic good result.
Based on that, my stupid question is how Europa Uomo can help Sergio. According to the comments I have got from the different people, I mean, we talk about let's face it in front of us. We talk about the project that will be implemented in 2 years from now, at the best. So, what do you expect from Europa Uomo? And of course, we thank you very, very much for your presentation. It was a lovely presentation, but I would like to know also if there is anything that you had in mind that Europa Uomo would help and support as long as this project will be implemented, let's say, or will be feasible in a certain time. What? Let's call it 48 months, or I don't know, 24 months, or whatever it is.
I think that one of the most important thing that we point to reach is information from patient, or not just patient, just to understand what is now the correct diagnostic process, the screening process, the patient journey, and what as the problem that the patient faced in the past during his last experience. So as I show you the results of that survey about what are the barriers that the patient face in the access of healthcare service. So this is one of the points that I think Europa Uomo can help us to their associate what was during their past experience the main problem that they faced in their journey, starting from the prevention to the diagnosis and after diagnosis. So, and another point is to understand if the benefits that we fix for our test. So in our mind, we collect information for a small group of urologists and patients to elaborate this test, so to decentralize the process, reduce the cost, and so on. So we want to confirm that the value of our project are in line with what the patient and citizen ask to researcher and the industry.
So thank you. I think there are no more questions, if I am not right. If I'm right, so we need to thank you very much, as Ioannis also and the others were saying, and we will try to tune with these ideas of collaboration, because obviously we are looking in the future. We have been looking in the future, and we understand that there is a very good base on these studies, and obviously we have in the same time the need to support and to see the confirmation from all the health studies and health organizations to put this in practice, for instance, in the early detection process, which is now they are studying the early detection protocols. Certainly they are studying now on what is certified like PSA, but it could change in the development while this product, this solution becomes more and more certified, I say, more and more clear for all the people. So thank you, Sergio, and we thank you very much, and we hope to continue our collaboration with Europa Uomo Europe and also Italy and the other associations of Europe.
So thank you for this opportunity to share our results. So we will attend the European Congress in Paris. So I hope to meet someone of you in the audience. So yeah.
We have already arranged a meeting in the booth, no?
Yeah.
Okay, very good.
Thank you.
Thank you. Thank you for suggestion and question.
Thank you.
Bye.
Bye, everybody.
Bye-bye. Thank you.
Bye-bye.
Bye.